received NACT. One from Kochi has a 50% utilization. So what are the reasons why many people do not receive neo at the bladder? Elective factors which can be modified. These are the criteria which decide whether you are cis. Now what is important to note here that a lot of us when made eligible, if you calculate creatinine clearance using the for a uro-oncology session, that really helps. I've started NACT in 7, completed in 5. Thank you.
Thank you. We're approximately 50% over last 3 years.
Everybody has a viral
MRI and
patients who are cisplatin ineligible. You may not know DDMBAC we are using very frequently. Which are the patients which you will not send?
Choose those patients wisely.
So follow up.
Yes.
lesion is there, then we'll send it to the
Line.
Good afternoon, everybody. In the next 6 minutes, I'm going to invasive disease that make them high risk for recurrence. Trial that proved the efficacy of adjuvant were offered nivolumab versus the 4 cycles followed by 8 cycles of eligible untreated.
but not on you.
The thing is, what I realize, a patient with on the IO mostly feels that he has never had chemotherapy. They feel so good. Not the patient who had hepatitis and died. But in general, when you they have hair falls and other things. But when you give IOs, somehow patients say, I just went had the injection, doctor, I don't feel like I had anything.
That's very true. There's a patient receiving atezolizumab or nivolumab for years. They are absolutely fine. They cannot make out they are getting any therapy.
So I think
side effect profiles which are completely different in chemotherapy and IO. Many other things, and I second your statement. I'm not antagonizing you, but a good medical oncologist should handle that.
yeah,
And the person
the problem is that like hepatitis and all, if not detected early and steroid not started, you lose your patient. So that is the problem with the immuno-oncologic agents. Thank you. Thank you. I think we'll move on to the next debate, which is on trimodal therapy. Yeah, please come, Rahul. You're the blessed one.
I'll be talking about whether trimodality therapy can replace radical cystectomy for clinical T2 muscle invasive bladder cancer. Conflict of interest, I practice exclusively uro-oncology. I've been fellowship trained in uro-oncology, so I may be biased towards that. An ideal case scenario showing at least PT2, and we would think that this is perfect for giving trimodality therapy. Why to do a radical cystectomy? Before we answer these questions, it's important to recognize that although we have been talking about trimodality therapy for a very long time now, almost 20 years now, that volume has increased